welcome to Department of Medicine Grand Rounds. I invited Dr. Ethan Booker and Dr. Lulu Wang to talk to us about telehealth, a very hot topic over the past year and a half. Here in the general medicine clinic, we're doing a ton of telemedicine. Last year, we were doing a lot in the setting of the COVID-19 pandemic, and we're still doing a fair number of virtual visits. In particular, it's been wonderful for chronic disease management and mental health follow-up, and certainly more frequent check-ins with patients who otherwise face a lot of barriers to showing up for in-person visits. And now not a day goes by I don't get an anxious text message from a colleague who's concerned about the future of telehealth. So we're all really looking forward to this talk. Dr. Booker wears many hats. He's a member of the Department of Emergency Medicine, and in addition, he's the medical director for the MedStar Telehealth Innovation Center and the MedStar eVisit program, which, as you guys know, played such an important role during the pandemic. He's also the co-PI on a large AHRQ grant pertaining to telehealth. And last but not least, he founded the MedStar Telehealth Fellowship. Dr. Lulu Wang is a current MedStar Telehealth Fellow who will be joining him to present today. Thanks to you both so much for joining us.
Our pleasure.
Well, thanks for having us, Miriam. Glad to be here. Glad to see friendly faces, or at least the names of friendly faces in our presentation today. So the objectives were flashed up before. These are the same objectives, so no different. And so let's dive in. And Lulu's going to talk initially about a case involving a couple of points of telehealth.
Yeah, this was a really interesting patient that really demonstrates the potential of telehealth to save lives. This is a young woman, 29-year-old, who was 24 weeks pregnant, came into one of our EDs at MedStar Montgomery, was diagnosed with COVID in April, and at the time was not hypoxemic, discharged appropriately, enrolled in our remote patient monitoring program, and using the pulse oximeter that we gave her, she was able to upload her vitals daily. And 4 days after discharge, she was noted to be hypoxemic. So using the platform, our team contacted her by text and then video call, and then determined that she needed to return to the ED. So this was where things got kind of interesting. So immediately upon return to the ED, she was transferred to Georgetown, put on high flow, and was actually intubated later on in her hospital course, and ended up being admitted for just under 3 weeks. Ultimately discharged home, and she's happy to say she and baby are both doing fine. But this is just an incredible case that highlights that telehealth really provides us with some powerful tools. With remote patient monitoring, we were able to safely discharge her after her first visit, but also keep a window on her progression at home and alert her when she needed to come back in. So rather than discrete episodes of care, we were able to create a bit of a continuum of care so that the patient, when discharged from ED, can still be connected. So we'll talk a little bit more about the logistics of how this happened later on, but just an incredible case. Next slide.
So one of the first objectives we wanted to talk about, and I hope to go through this reasonably quickly, is kind of COVID response via telehealth. And MedStar's experience with a COVID response in telehealth is not terribly dissimilar than most of the rest of the countries. But I want to spend a little bit of time talking about where we were prepared for this response. So the MedStar Telehealth Innovation Center, where my job mostly is inside of MI2, the MedStar Institute for Innovation, which has been charged now for a dozen years with preparing for what's next. And sometimes preparing for what's next, like in the case of telehealth, means a lot of excitement in 2009 about telehealth being right around the corner, and then a decade of kind of waiting for the shoe to drop, which it kind of finally did in 2020. We accelerated our preparation around telehealth specifically with the founding of our center, MTIC, in 2017, with the charge to develop expertise, to do planning around telehealth, and to do some of the initial pilot and program management and support. So we were in a position in early 2020 where we had some things on the ground, we had some things spinning, we had some things at pilot phase that we were able to accelerate significantly. Before we dive too much further into that COVID response, Lulu's going to run quickly through kind of some vocabulary around telehealth just to make sure we frame set.
Yep. So some of the broad categories that we can divide telehealth into are these two buckets here: consumer telehealth and consultative telehealth. So consumer is when the patient's directly interfacing with some sort of medical care. So examples of this, some of which you've seen, are video visits or e-visits, essentially the provider and the patient doing a two-way video call, or remote patient monitoring or interacting through a web app or a chat bot. So this is also known as B2C, or business to consumer. And on the next slide, we have consultative telehealth, in which interactions are happening within the medical system. So for example, telestroke or tele-ICU, where the specialist is providing their expertise to the provider at the bedside. Teletriage, in which ED providers assist the triage nurse, or e-consult, in which health data or photos are stored and forwarded to a specialist for later review. So no direct interaction with the patient. This is also known as B2B, or business to business.
So with just a little bit of that context, and we'll go through some very specific examples of the work that we do and have done at MedStar to give some examples of those B2B and B2C roles, but just to dive back to the COVID response, kind of a sense of where we were and what we've done. In 2017, we chartered this group. We spent a couple of years kind of coiling the spring against some really significant barriers to execution of telehealth. A little bit of it technology, a lot of it policy and reimbursement, and some of it really cultural demand. Patients didn't really shout out for it that they wanted it, and providers by and large weren't also clamoring to do it. And so there were a number of barriers that existed, which were sort of suddenly removed in March of 2020. And that barrier was removed, both the legal barriers, the policy and reimbursement barriers, but also the cultural ones that drove people towards adoption. And so a year's worth of pandemic response went from really, very minimal use of telehealth. When we look back at sort of pre-COVID monthly volume across some of these B2C and B2B activities, we were doing a fair amount of B2B activity. It was actually mostly the teletriage activity, but really not a lot of B2C or consumer facing stuff through either e-visit or scheduled video visits. So as a monthly volume, it just exploded. Such that by the beginning of this calendar year, on a monthly cadence, 5,000 or so on demand, close to 50,000 scheduled video visits across the enterprise, and more than 10,000 B2B consultations across the enterprise on a monthly cadence, such that we got to 750,000 video visits in the pandemic year response. If you add in audio only, which I know Miriam has been very vocal about the value of the audio only experience, you add that in and it's more than 1 million remote contacts in the pandemic year response. What we were doing prior to COVID was working with a handful of folks who were sort of pushing boundaries. And I see Kat Walker on our call. Kat was certainly one of those people that was doing telehealth pre-pandemic. But it was really a small number of people who were doing it. And now at the numbers that we have now, it's essentially an enterprise skill with thousands and thousands of people who are capable of doing it. We could spend some time talking about the logistics of doing that, of technical enterprise solution, educational processes for training and things like that. But I think a lot of you are probably pretty familiar with that. I want to spend a minute talking about the role that telehealth had relative to the in-person environment and kind of across some different service lines. This is a look back over the course of 2 years worth of ambulatory activity. The crisis moment of March 2020 is represented right in the middle of this graphic, which goes back to March of 19 and then comes forward to March of 21. And you'll see the massive disruption that happens top right graphic with the blue line, in which you see a precipitous drop in our in-person visits as we're sort of going along, and then suddenly offices are either significantly restricted or patients are concerned about coming into them. And there's a rapid recovery using phone first in orange, followed by green, which is the video response. And you'll see that over the course of March and April and May, an enormous amount of the work that we were doing was done by video, with phone gradually tailing off and then people gradually returning to the office as they came in. It varies quite a lot by service line. So this is a breakdown in the middle column by service line, and with some interesting findings. And then in the middle of the right side column, a really interesting discovery of no-show rates. So one of the things that was really interesting about the response of making telehealth available is that because you're doing it from your house, no-show rates actually drop. And we've managed to demonstrate that this is a sustained phenomenon across all service lines. And in the vast majority, this change in no-show rate is statistically significant. Now, whether or not it's administratively, business-wise, clinically significant is a different question. But from a statistical perspective, the change in no-show rate afforded by telehealth is significant. The last thing I want to point out on this graphic is the thing on the left, which is the total number of visits in the pre-pandemic year and in the pandemic year response. And you'll notice that there's actually a slight decline. That disruption of March and April of 2020, and to a smaller extent, the disruption of the third surge in November, resulted in us doing fewer ambulatory visits as a health system over the course of a pandemic year than we did beforehand. We'll get into this a little bit later, which is the very important policy implications of this difference. There is significant concern at the federal level for reimbursement of telehealth going forward, that telehealth is additive, that it's just another thing that someone's going to have to pay for, and patients are coming in and getting a second service anyway. And our data is pretty conclusive about this, that from an economic point of view, it is a substitution. Clinically, it's complementary, meaning that you kind of need both, given the clinical circumstances. But from an economic perspective, it's a substitute. Diving into the on-demand, I think, as Miriam said, there is a significant, a lot of people had experience with this, looking at this very, very steep rise in the beginning of the pandemic response in March, where we went from really zero to hundreds of patients a day who were coming to us for MedStar eVisit and receiving services. MedStar eVisit made a decision in March that we were going to offer this service for free. That basically we were going to waive all charges for this. We put the paywall back up July the 1st, so just a few weeks ago, to begin charging for the service before that we had charged before. Most of it's covered by insurance, and so out-of-pocket cost is still pretty low for on-demand services for patients. But we are incredibly proud, and we should be proud as a health system, that we provided 75,000 patient encounters in the pandemic response, on-demand eVisit, with a wait time of about 6 or 7 minutes, free of charge to our community. I have some really interesting geographic data about this, about how well it reached into wards 7 and 8 in DC, and how well it reached into PG County, and how well it reached into South Baltimore for adoption, and how many of those patients did not have another source for care. I think this is a really important community benefit, and we're still digesting exactly what that community benefit has been in terms of doing this. But this was a really pretty significant response on MedStar's part to make sure that we were serving our community. There were other reasons to do it. Particularly in that early surge, the ability to not have people overwhelm our emergency departments and urgent cares, particularly when testing was pretty limited and treatment was zero, of people who were concerned. We kept a lot of those folks at home. But importantly, and here's a distinction I want to make about telehealth that I think is important to drive home, is it's not always a destination to get care by video. Sometimes it's an important part of the navigational process to know where to go to get the appropriate site, the appropriate thing for care. So over the course of our pandemic response year, eVisit sent 12,000 patients to testing tents, and 8,500 or so to an urgent care for in-person evaluation. And about 3% of those patients who come to MedStar eVisit are rerouted to an emergency department. Many of those people who come and are rerouted to an emergency department are pretty confident they need an emergency department, but they want reassurance. They want to know that they're making the right choice, because sometimes it actually means significant out-of-pocket dollars to go to an emergency department, not to mention the hassle, and certainly during COVID pandemic response, the risk. So we did a lot of navigation with eVisit, which I think will continue to be a big part of the value of how we think about telehealth and how we think about the clinical activities that are possible with telehealth going forward. You know, this should not be, it cannot be just a vendor-driven solution to prescribe antibiotics to people who don't need them, right? That's not what we should be doing with our on-demand telehealth approach. We should be providing care where it's appropriate and then navigating people to care where they need it. I'm going to pivot into some of the B2B activities that also accelerated during COVID. One of them is within our emergency departments, the MedStar Acute Care Coordinating Center, the MAC3. The way that emergency departments have always worked sort of historically is you come to the emergency department, you see the triage nurse, you wait for a while, they put you in a bed, and then someone comes and sees you and gets started. For a decade or more, busy emergency departments have upended that process by putting providers much further forward in the process and doing a provider and triage model, where rather than waiting and waiting and waiting for sort of definitive judgment, somebody gets you started right away, right up near the front door. And we've at MedStar done that in physical locations for quite some time. But in 2016, we virtualized that experience at Washington Hospital Center. And then in 2019, spread it out to a couple of different places. And then the pandemic actually drove us to adopt it across the entire enterprise, where essentially a single group of providers is spread out to 8 emergency departments, 33 urgent care locations, and is also available to the MedStar Home Health Care organization. We did some connections to skilled nursing facilities outside of MedStar during the pandemic response. That was small numbers, but pretty critical when it was there. I'll dive a little bit back into the MAC3 and its future perspective in a few minutes. But I wanted to talk about something that's not necessarily about sort of clinical operational stuff, but instead patient and provider testimonials about the meaning and the value of telehealth. And I think those of you who've spent time doing telehealth may have had similar sorts of experiences, but the ability, particularly for the acute care settings, a lot of our eVisit providers and the MAC3 providers come from emergency departments and urgent care places. And many of them were pulled out of their regular jobs for one reason or another, and did telehealth to a great degree over the pandemic response. And I think that the provider experience of telehealth is something that we can use to address burnout and wellness if it's done effectively. The other thing I wanted to point out is the patient experience of this. I think, again, if you've had interactions with patients over telehealth or had the ability to get feedback from them, you may have heard from them how good the experience can be. The experience of healthcare for most patients is not great. If you look at any sort of score that does net promoter scores or like experience scores or stuff like that, you will not see 97% level 5 feedback from patients about what their experience has been. And we now have hundreds of thousands of patient experience feedback scores about the experience both of the platforms, which have performed really well, but actually much more than platforms, patients like the provider experience. They like connecting with their doctors, their PAs, their nurse practitioners this way, and have given us feedback to the effect that patients are satisfied with this way of delivering it, which is one of the things that we'll talk about sort of looking forward, is that patients have now gotten used to this and they're going to want to use it. Pivoting back to the B2B activities that we talked about in the MAC3, I want to dive a little bit into the mechanics of one of them, because we're going to talk about it as a forward-facing opportunity. And that's what we do in the teleconsult realm into our urgent cares. So as some of you are probably aware, our urgent care footprint expanded quite significantly recently with the acquisition of a company called Right Time, which took our footprint from 14 urgent cares to 33. So we now have a very large footprint of urgent cares. And in each of those urgent cares, there's a cart that looks like this one on the left, that you can log into with your MedStar credentials and enter in the patient's name and get a large number of resources. Interpreting services, including American Sign Language, is one of them. But this is how an urgent care provider gets a hold of an emergency physician to give consultation or care coordination advice. They can do pediatrics consultations. They can use their own providers for surge management in their urgent cares. And as of a few months ago, able to get a cardiology consultation in the urgent care in a response time of somewhere in the neighborhood of 5 or 6 minutes. We've now done about 400 of these cardiology consultations. Dr. Alan Taylor is the primary driver of that. So that growth of the MAC3, the B2B, again, went from relatively small number of encounters to a very large number of encounters. It's now 100,000 or so annualized. And also a really important bit of workflow that was made possible by changes in law about medical screening exams and a workflow called Evaluate, Treat, and Disposition, where a patient arrives in the emergency department, is seen by the triage nurse, meets a set of criteria for low risk circumstances. Most of this is COVID, and can be evaluated entirely by that remote provider and then discharged. So we were able to do more than 2,000 of these in our emergency departments, and urgent care has used a similar workflow for more than 4,000. And we've been able to demonstrate really good outcomes and published peer-reviewed studies about outcomes for the first 1,000 or so of these patients that we saw. This is the year's worth of look back about that activity. So 84,000 patients in that MAC3 activity of a distributed delivery activity service. So that was a bit of a whirlwind about COVID response. I went through it pretty quickly because I wanted to spend much more time talking about kind of looking forward and hopefully answer questions about the sort of regulatory policy and advocacy space. But if it makes sense to pause there a minute and ask about if there are other specific areas within that COVID response that folks are interested in.
I don't see any questions in the chat, Ethan.
Great. So I'm going to cover 3 kind of specific areas here about the regulatory and policy environment. If you're paying close attention, and I know all of you who are providers in the audience got communication recently about this, but our 3 states jurisdiction area that we span recently concluded the public health emergency, and the end of that public health emergency resulted in the end of the waivers that allowed some flexibilities in how we did telehealth. The most important one being licensure. So a bit specific, getting into policy a little bit. To provide healthcare, you have to be licensed in the place where the patient is. Now, this was always really straightforward when someone had an office where they went to work and where patients came to them. Telehealth has made this far more complicated. I mean, some people have multiple offices. Many Georgetown providers included, have offices in multiple places. But by and large, providers are licensed in one place in a sort of classic model. Moving into the telehealth world, you have to be licensed where the patient's feet are. And that had always been the case, but that was one of the things that went away with the waivers on the public health emergency and has now been reinstated. The conclusion of the public health emergency meant that we have had to sort of address this issue. In Virginia already, and so a lot of the organization is actually kind of scrambling right now to pursue Virginia licensing, if that's part of their practice. In Maryland, the waivers expire August the 15th, and in DC, the waivers expire September the 23rd. And so we're in the process of supporting lots of different parts of the organization to understand when and how they need to get licensing. And we've built a tool to help us understand at the provider level where it makes the most sense to help people get licensing. And so individual service line leaders have access to tools to help them understand, which of their services, which of their offices, which of their providers should really be pursuing multi-jurisdictional licensure. The short answer for Georgetown is the District of Columbia is not very big. Georgetown has a pretty big catchment, and many Georgetown providers are going to have to be licensed in all 3 jurisdictions. But that's often going to be a service line by service line or even provider by provider activity, obviously with the support of MedStar when it makes sense. There is considerable uncertainty about some aspects of telehealth and telehealth reimbursement, but there are some areas that are actually pretty well settled law. Maryland passed law this year, active starting this month, that actually enshrines telehealth and telehealth reimbursement in law going forward. There are some parts of this that sunset, and importantly, audio only is one of the areas that sunsets in Maryland. It sunsets June of 23. And also payment parity is part of the law that sunsets in June of 23. So the distinctions one makes in policy here is that there is coverage parity, there is service parity, and there is payment parity, and they're not all exactly the same thing. But Maryland has the most advanced version of this, at least for now, which is for Medicaid and for commercial payers, telehealth includes audio only, and telehealth is reimbursed on the same basis and at the same rate as if the healthcare service was delivered in person in a non-facility setting. This is very good news for MedStar as a whole, as we pivot somewhere between 10 and 15% of our ambulatory volume to video, and some portion of that also to audio, that we can be reassured in Maryland with Medicaid and commercial payers of reimbursement going forward. DC has a very similar law. It's actually been enacted for quite some time. The last little bit of area for policy and advocacy is about Medicare payment. So the state is responsible for licensing and for rules covering Medicaid reimbursement and commercial payers. The federal level is the place at which Medicare reimbursement is driven, but Medicare reimbursement obviously sets the tone for all other areas of activity. Medicare broadly allowed telehealth under the PHE-related waiver, but prior to that waiver, there were significant restrictions as to what one could do via telehealth. Specifically, the originating site for the activity was, generally speaking, required to be a facility, and it was a rural activity, meaning it had to be a rural census tract activity. Generally speaking, it couldn't be done from the beneficiary's home. It had to be done from an office or a hospital, with the idea that telehealth, as it was conceived by Congress when it was originally paid for, was an activity in which people in rural settings were getting assistance in rural hospitals from urban hub type hospitals, meaning that the University of Iowa was providing critical care resources to rural hospitals in Iowa. That's how telehealth was always conceived of at the federal level. It's obviously not that, and access is a problem everywhere, including in urban areas and including places right under the shadow of places like Washington Hospital Center. So there are 31 bills in Congress currently that have something to do with telehealth and updating these rules. Many of them are not useful to how it is we envision telehealth going forward. And the primary sticking points at the federal level for reimbursement policy are the budget impact, like I described. Is this an additive service, or is it, from an economic perspective, a substitution? Meaning, is this just paying extra for stuff that people are going to have to come in and get in person anyway? Are we just tacking on more dollars? And then also substantial concern, not particularly well-founded concern, about fraud, waste, and abuse. Meaning, are people going to set up offshore telehealth companies and defraud the government for millions and millions of dollars? There's really nothing about the way in which we conceive of telehealth as a health system that is problematic for Medicare's overall expenditures. We've demonstrated very effectively that this is a substitution economically. And we have an enormous footprint of in-person services. We're not we're not going to be having problems of fraud, waste, and abuse. The only ways that we're going to have trouble in billing Medicare for services done via telehealth is when the regulations are confusing, which they often are. So,
and there's a couple of questions. Do you want me to just ask?
Yeah, why don't we go into that and then we can look forward.
Yeah, there's a couple of questions I think about that kind of gets back to the issue of like state versus federal, CMS versus Congress. So one of the questions I got was, what about the national PHE, which has been extended for 90 days? Another question is, could CMS step in and allow telehealth across state lines?
Yeah, both great questions. So the PHE was extended for 90 days. What I hear from those folks who have their ear to the ground about this is that flexibilities associated with the PHE will be extended through the calendar year. The advocacy position that MedStar has taken, along with the primary national advocacy organizations around this, the primary one that we're involved with is something called the Alliance for Connected Care. Our primary advocacy push is a 2-year extension of the waiver flexibility for originating site and for reimbursement parity. There's a lot of optimism that that will be the case, that we'll actually be able to operate essentially under the waivers that we have for enough time to gather the information that we need. As you mentioned at the beginning, I am a PI on an ARC-funded study in collaboration with Stanford and Intermountain, which is looking specifically at these areas of telehealth and primary care, the significant disruption in March and April, connections to care, demographic differences, issues of access and equity, and also trying at least to begin to look at outcomes of folks who are using different modalities for care. So there's no way we can make a good decision from a policy perspective based only on the information we have now. And our hope is that we can that none of those 31 bills actually get put into place before we have an opportunity to inform better policy.
And
the issue
that
of
question
yeah,
popped
the second question, sorry, go ahead, Miriam.
Oh, that same question popped up when you were talking about the end of the state PHEs. So it's just an important reminder that like the national PHE is kind of separate from the state allowed flexibilities.
Correct. And there's always the possibility of a sort of discontinuity between the public health emergency and any waivers that were tied to the public health emergency, because they could in fact be sort of disaggregated. The question of whether or not CMS can step in or the federal government can step in about these state-based things is a really interesting one. The short answer is no. State licensure is one of those things that's fairly well enshrined. But the question is whether or not the federal government can come up with some ways that actually compel states to do a better job of reciprocity. And don't create a circumstance like we have now, which is you have to start from scratch in every single state. And obviously, importantly, from the perspective of these various state boards, you have to pay them their somewhere between $300 and $700 per license to be able to practice there. So some folks have proposed things along the lines of the adoption compact. 50 years ago, 60 years ago, if you adopted a child in a state, the state recognized that adoption, but it was possible the neighboring state did not. And so an adoption in one state didn't necessarily mean that you were the guardian of that child in another state if you crossed state lines. That's obviously nonsensical. And so the federal government stepped in and said, basically created rules of the road that every state had to agree to a compact that recognized other states' adoption laws. And so there's a precedent in law about this kind of thing, that's state-based regulatory environment that actually is federalized in a way as to make some sense of the thing. Our particular perspective here, again, the the advocacy position of MedStar and the Alliance for Connected Care is to create medical excellence zones, and they're particularly focused on DC because of its impact on federal law. To create a medical excellence zone that's DC, Maryland, and Virginia. The idea here is licensure in one of those jurisdictions would carry across all three, with the idea that we could create a continuity across that environment. We've spoken to the University of Maryland and to Hopkins about this. They are on board. There's been some movement in DC Council and in Maryland legislature, but that's probably a few years off. And so it's probably going to be a state-based alliance regionally that creates a solution that's helpful for us here. But I do think there's also places where the federal government can be helpful, and CMS could be helpful about things that are probably really important to Georgetown. And what I mean by that is nation-based, nationwide referral networks for highly specialized skill sets. So for instance, someone in Missouri has a cancer that's best suited for us here at Georgetown, and their local oncologist wants to consult with us about whether it makes sense for that person to come to Georgetown to get further services. Can we provide that consultation to Missouri? And can we create a network that allows us to do those B to B type consultations without being licensed in every state across the United States with all of our subspecialists? That's an area where Congress probably can act to help us understand, not necessarily how to get licensed in all those places, but what are the boundaries that allow us to do those sort of one-off consultations to allow for better access to care in places that may not have the resources of a place like Georgetown.
I think that's it for questions right
Great.
now.
So let's move on to looking forward, and hopefully we get a chance to kind of ask to get questions here, because again, I'm the medical director of an innovation center. Like this is where I want to be talking about. This is where I want to be, is not just like what can we build, but also like why is it still important to build telehealth? So Lulu, do you want to take it from here?
Yeah, so certainly some uncertainties incipient with telehealth, but I think despite all of that, we'd all agree that telehealth in some shape or form is here to stay, right? It's progressive movement forward, and there are some very unsurprising reasons why this is an area of interest, both from within healthcare and from private entities like Amazon and others out there. There's a lot of growth and there's a lot of interest right now. So some of the major reasons are illustrated here. Telehealth really does help break down some of the barriers that have traditionally limited healthcare delivery. So as we talked about above, it improves accessibility, right? So for patients in rural areas or any patient with issues with mobility or childcare, or they just can't take half a day off in order to see their doctor, telehealth is a tool that they can use in order to continue their care. Efficiency. So instead of one triage provider in every emergency department, we can staff a core group of triage providers across all 10 of our hospital EDs, or one ICU doc can oversee several tele-ICU, maybe remote rural tele-ICU units, et cetera. So both you as the provider and the patient are able to maximize efficiency. You're not spending time waiting in traffic in order to connect with each other. This work, for the most part, is much more scalable than the brick and mortar care that we're used to, right? So once the digital infrastructure is built, you can add on an unlimited number of providers or patients or other ancillary staff, and remove some of that geographic and otherwise physical limitations that we saw previously. And because of these three, telehealth can also provide cost savings for our healthcare system. And more importantly, it's a vehicle for change towards value-based healthcare, which is something I think as a nation we are interested in moving towards. Back to you, Ethan.
So again, sort of thinking about what's next and what's forward, one of the visualizations that we in the Telehealth Innovation Group have been sort of talking about is trying to take what I mentioned up before about eVisit, which was about, like, it's not just a destination, but it's a tool for navigation and entry into our health system, is to move the language that we use from one that's focused on the transactional interactions, many of which are hugely valuable, into something that's a more continuous opportunity for care. And so, again, a bit of vocabulary here about the language we're using. Telemedicine very specifically means essentially healthcare, which is usually something that can be encoded with a CPT code that is done via technology. Telehealth is a slightly broader term that actually encompasses some things that are beyond what telemedicine which is usually just asynchronous video, would include. So some of these real-time navigation and rapid access and family engagement, remote patient monitoring, those things fall better into the rubric of telehealth. And then connected care, a broader term, and something that most of the people in the industry are now pushing forward to really describe not just the technology interaction, but kind of an ecosystem that wraps around the patient, and being really thoughtful about the connection between what's done remotely in a patient's home and what's done in person. That these two things are not separate silos, but that they can work in complement. And so kind of the pinnacle of continuous connected care would be a kind of chronic disease, remote patient monitoring, very frequent, data-driven, almost continuous communication and monitoring with the patient to drive towards better wellness. There are ample opportunities in this space. And as we think about that movement from transactional telemedicine encounters, which we started doing a decade ago with telestroke, into more continuity-based care with connected care, we're looking forward with what our priorities are as a telehealth center to make sure that we're maintaining this infrastructure we've built during COVID, doing the things we talked about in advocacy and policy to make sure that patients get what they need, that providers are supported in doing it, and don't have burden in doing so, and that we do so in a way that's financially sustainable, both for patients and for health systems. And then the most fun part of the work is to collaborate with people to think about how we can deliver care in a way that's better for patients, again, more scalable, more financially sustainable, and really think about what's next in the way that we deliver care. One of the things that's really exciting about what we're doing right now is Lulu, and our inaugural Telehealth Fellow. And I'll have her sort of talk a little bit about what we're doing in the education space.
Yep, that's right. Inaugural Telehealth Fellow. So we do accept all comers from IM or EM. So for those of you in the audience who are piqued by this conversation, we can talk a little bit more later. So just briefly, this is a one-year fellowship. And it is kind of spans the entire breadth of telehealth, but with opportunity to focus on one or two specific areas. So the curriculum includes education on care delivery, business development, revenue generation, kind of interesting for us as clinicians because it's something very different from the learning that we traditionally get through our medical training. A focus on research and publication with opportunities to teach with the residents and medical students. And then also getting diverse resources and faculty mentorship. So one of the things that's really interesting and unique about this fellowship compared to others is that it really, telehealth slices through the entirety of MedStar as an enterprise. So you could be talking to a MedStar executive leader 1 minute and then working on something much more granular the next. So you're interacting, you're learning from people across the entire spectrum, and you're not siloed to your one specialty or even your one hospital. It truly kind of touches everyone across the board. On the next slide, some of the current projects that I'm working on are two, one of which is leading a cohort of EM residents through a QI project following our COVID remote patient monitoring program. And I'll tell you a little bit more about that in a few slides from now. And then improving transitions of care with our Telehealth Technology Coordinator, which you heard a little bit about. So just generally taking problems that have not had the opportunity to be solved in an eloquent way up until recently, and figuring out if we can use telehealth as a tool, not the only tool, but as a tool in order to improve patient care. That's my email. So again, anyone who's interested, feel free to email and we'll set up a time to talk.
Great, thanks, Lulu. And so diving into a couple of examples, and this is not necessarily the entire spectrum of what's going on right now in the organization or kind of what we're doing going forward, but I wanted to highlight a couple of examples that I think are particularly relevant. So starting in November, sort of in the midst of third wave, we started a program called Connected Primary Care. Some of you may be familiar with this from experience with it, but essentially the model here is a nurse practitioner and MA who were newly hired as the clinical workforce for this, that support a pod of primary care practices. In this particular circumstance, the first one was in the Olney Gaithersburg area, 5 practices, 5 MMG primary care practices, 21 providers who had full panels. Many of them had very full panels. And a nurse practitioner who was hired along with an MA to take a lot of the activities that were either really burdensome or were actually limiting access to patients and take those on. So one of the first activities was same day and next day availability by video. So one of the realities of these primary care practices is patients were calling saying, I want to come in and see my doctor. I've got X, I've got Y, a lot of COVID complaints during this period of time. And having that primary care office say, I do not have any availability with your doctor in the next X amount of time. And so we plugged that hole with a nurse practitioner to say, there's someone available to see you today or tomorrow by video, supporting all of those practices. And she very quickly got to speed with the number of patients that she was seeing. Now that would have been an important intervention by itself. But the other thing that team is doing is also enrolling patients in hypertension remote patient monitoring and monitoring patients with chronic diseases, as well as being the provider for an automated prescription refill process, looking and filling gaps in care, and doing lab callbacks and other portal message type activities on behalf of those 5 practices. So what we've been able to demonstrate is improved access for patients, a new activity of remote patient monitoring, and decreasing some of the burden of practice around portal messages and lab follow-ups and all the stuff that many primary care providers are doing after 6 p.m. at home that are pretty contributory to burnout. We've gone live now with 3 pods as of 2 weeks ago, and also filled a gap that some of you may be familiar with in the Spring Valley practice. That's the family practice that actually has a fair number of Georgetown faculty who go back and forth to, where providers from MedStar eVisit are now taking same day and next day appointments in that schedule to allow access to same day and next day appointments in the Spring Valley practice to fill in a gap there. This week we'll go past 1,000 of these same day, next day appointments. And interestingly, we've also been able to demonstrate that these practices that the nurse practitioner is supporting are growing. So the providers whose patients are being seen this way are getting busier with new patients and higher complexity patients that they're seeing in the office. So from a business perspective, it's actually growing the RVU productivity of the providers that are in these practices. It's not cannibalizing their activity, it actually grows the pie. A B2B activity that's very exciting is what I mentioned earlier about the urgent cares. So there's a ton of data here, and one of the things we've had the great opportunity at MTIC to be able to do is have a lot of interaction with Sitel data scientists and with MHRA data scientists to build some really compelling visualizations of the work we're doing. On the right here is a 6-month look back of that urgent care consultation model that I described, where in all of our urgent cares, there's a device that allows a provider to push a button to get consultation, language services, or one of their colleagues to help them out in surge. And so over the first 6 months of this calendar year, There've been nearly 6,000 of these consultations done. Many of them are care coordination to get patients safely from the urgent care to the emergency department. But this has documented nearly 1,000 patients who've been able to avoid an emergency department transfer from urgent care to emergency department. Being sent from an urgent care to an emergency department is an enormous dissatisfier of patients. They're very unhappy to have this happen to them. They're really unhappy if they then show up in the emergency department and not much happens. So we've been able to demonstrate a bending of that curve, and we're taking this information to MedStar Family Choice, to Care First, to demonstrate that this connected model can be really in the payer's interest to do stuff like ED transfer avoidance from urgent cares. As I mentioned, there's also cardiology consultation, pediatric consultation, and this urgent care work that's allowed the urgent care providers over the course of the first 6 months of this calendar year to see about 1,500 patients in the urgent cares by a remote provider that provides the kind of scale that Lulu spoke to, where rather than calling in an extra person because you're getting overwhelmed, if you're getting overwhelmed, you can call for help and get help for an hour or two to bail you out. And then the next, that person can pivot to some other place to be effective in some other place. One specific area that I had waited to call out until sort of the tail end of here is behavioral health. Telehealth's been really important across a lot of the business of MedStar. Obviously, in primary care, there's been a big change in the way that we've done a lot of the work we've done. In neurology and some of the other specialty services at Georgetown, big changes, but nothing is anything like what's happened in behavioral health. Very quickly in the pandemic, behavioral health ambulatory services pivoted to remote, first phone and then video, and they have remained predominantly that way. Across our behavioral health ambulatory footprint, only about 4% of patients are coming into the office anymore. It is categorically different now than it used to be. And interestingly, there have been some new providers, but we have grown the access of behavioral health in our ambulatory footprint at a time when access to behavioral health has been critical. And part of that is about what's seen here down at the bottom, which is a decrease in the no-show rate. Now, it's always complicated to get, especially to Georgetown, always complicated to get to an appointment and to get to an appointment on time. If leaving the house is a problem of your disease, like depression and anxiety, even more so. And so the availability of care in people's homes via behavioral health has been game-changing. Fortunately, this is the place where the policy has been fastest and has been most protective of both reimbursement for physician services, but also for other professionals providing these types of services, and also for audio only in circumstances of behavioral health care and in substance abuse. I think this is, whatever else happens in terms of where telehealth is going, this has changed and will stay this way. This is a permanent change in the way that we do behavioral health. Briefly, I wanted to talk about inpatient care. And one of the challenges there, and I saw that Kat was on, and she's really the big driver of this for palliative care, is the ability to deliver last mile in the inpatient setting. One of the real challenges in the B2B world, particularly we're talking about sick patients in hospitals, is how to get that patient actually engaged to a remote provider. And so we've developed a workflow that includes a person who's getting devices to bedside, facilitating interactions, and creating the ability for Kat and her palliative care team to spread their resources out through the entire organization and meet the needs of people weekends and evenings and things like that that were really difficult to do if they had to spend windshield time getting place to place. We could spend an entire hour talking about this, and Kat and I have spent many entire hours talking about this work, which is really important. I want to wrap up in terms of like what we're doing clinically with the model that Lulu talked about, and have her talk quickly about the ED discharge. And then I'm sure, Miriam, there's some other questions to get to.
Yep. So briefly, since I know we're a little short on time, so care transitions is something that I and the entire telehealth team is very interested in. It's a particularly challenging time. So patients come to the ED, they're admitted, we discharge them, and we say, okay, follow up with so-so and this person and X, Y, and Z, and good luck, and hopefully you don't come back. But as we all know, that's not an ideal situation, and especially for our COVID population in the last year, the post-discharge time can be particularly dangerous. And so back in December of 2020, we launched a remote patient monitoring program from our emergency department. So anyone with COVID or highly suspected PUI, we offered enrollment. It essentially comprised of sending patients home with a pulse oximeter, many of which were Bluetooth enabled, meaning that the patient, once they've enrolled the device, could just put the pulse oximeter on their finger and it would automatically upload their oxygen saturation data. And our team on the other side were monitoring this 7 days a week, 12 hours a day, and also offered unlimited phone support, text support. Some people wanted us to call them twice a day, every day, even if their SATs were fine. And the vast majority of patients who expressed gratitude for this said they felt that they were still being checked in on and made sure that they were okay even after they were discharged. So again, to follow the theme of the day, we need to stop thinking about care as discrete episodes of care and more as a continuum of care. So rather than waiting for the patient to bounce back to the ED or the hospital because they had questions about their post-discharge care, didn't know who to get in touch with, or couldn't get in touch with them, we can be more proactive about identifying these higher risk patients and providing them with tools to do well in the post-acute period.
So a bit of a whirlwind, but I've been working on this stuff for 6 years. So compressing it into 60 minutes is sometimes challenging, but I really appreciate the opportunity to come and speak.